Before discussing the total approach to scrotal symptoms, I would like to dedicate a couple episodes to each one of the specific diagnoses, given the high significance and importance of knowledge in each one of those categories, and then discussing some differentials for each one of them before putting the whole thing into a single approach algorithm. With that in mind, in this episode I would like to discuss the two initial rule-out categories of the scrotal pain, and those are the two T's, the torsion and testicular trauma. What is the very first step in the assessment of a patient who comes with any type of testicular symptoms, including pain or swelling or redness? The very first step is the evaluation of presence or absence of the four cardinal symptoms of testicular torsion. Why is this important? For several reasons. First and foremost is the torsion being the true emergency may require immediate surgical exploration, and there is just a very limited viability window for the impaired blood supply to the testis. In other words, the rationale is we do not want to spend any time for assessment if we have very high pretest clinical probability. We may even avoid doing the Doppler if we could have a surgical exploration available quickly. What are then the four cardinal findings indicating torsion? One is an acute onset of pain, and that is abdominal, inguinal, or testicular and scrotal pain starting in the last 24 hours. Second is nausea and vomiting. Third is high riding testicle or a horizontal testicular lie. The so-called bell clapper deformity is the way to describe it sometimes. And the four is absence of cremasteric reflex. If any of these four are present, we need to rule out torsion. But if all four of them are present, the torsion does not need any further workup, including Doppler, and the patient immediately goes to surgery. What is the next step in decision making in this patient? If the surgery is readily available, we do not attempt detorsion in the emergency room. But if surgery is not readily available, we attempt detorsion first. Now, if any of these symptoms are present, but not all four of them, in other words, we are not dealing with a very high pretest probability, but we are dealing with low or moderate pretest probability. What is the next step? Stat Doppler ultrasound of the scrotum. Again, we do this investigation only if we are not dealing with high probability. That is, not all four of the cardinal symptoms are present at once. What is the finding in this situation? Absence of blood flow. Case. We have a 14-year-old boy with 3 out of 4 cardinal symptoms of testicular torsion that initiated around 16 hours ago. Now we have performed testicular ultrasound and we noticed presence of heterogeneous echo texture and absence of blood flow in the spermatic cord. What is the diagnosis? Diagnosis is testicular torsion that is complicated into testicular necrosis. Remember that necrosis as a late finding happens after 12 hours of torsion and manifests as heterogeneous echogenicities in the ultrasound Doppler. Is there any other symptom possible than the 4 cardinal findings? Yes, the scrotum is usually extremely swollen and erythematous. Important question, what are the differential diagnoses of absent cremasteric reflex? Always remember spinal injuries, surgical traumas, as well as testicular torsion. What kind of surgical operation could cause this, any surgeries in that region, for example, hernia repair. True or false, absence of cremasteric reflex is sensitive and specific for torsion. That's false, and that's why we say all 4 cardinal symptoms together should be present for clinical confirmation. As we mentioned, there are other possible differentials for absence of cremasteric reflex. Now, regarding the timing of intervention for torsion, what are the golden times? If any kind of surgical or manual detorsion successfully is attempted within the first 4 to 6 hours, the viability is usually 100%. But if the intervention and detorsion is delayed for 12 hours, the viability probability drops to 20%, and after 24 hours there is almost zero likelihood of testicular viability, unfortunately. Now, when do we attempt manual detorsion? If you remember the open book maneuver that we do only on the side that requires detorsion, the rule is we perform an ED attempt, an emergency department attempt of detortion, when the surgical intervention is not readily available within the golden 6 hours. What is the surgical intervention? Immediate surgical intervention with bilateral archaeopexy. Why the intervention needs to be bilateral? The fixation needs to be done on both sides given the high rate of recurrence. Now, on conditions without 4 cardinal symptoms being positive, that is moderate to low probability, what is the next step? In addition to Doppler, we also perform some labs such as urine analysis. What's the significance of this? To rule out the other important differential of acute scrotal symptoms, and that is epididymitis. Now, a question you may hear is, what's the next step? If the surgery cannot be attempted within the first 12 hours and unfortunately ultrasound shows necrotic tissue, remember that unilateral archaeectomy should be attempted. Why is it important to perform archaeectomy? Because if the testis is left in place, the necrotic tissue undergoes inflammation and attracts anti-testicular antibodies that can destroy the other testis as well. So you may hear this question, and this is also important for management and cases, that the parents may ask you or the patient may ask you what will happen to the fertility after this archaeectomy process. Remember that fertility would not be affected if one testicle is intact, and especially if the archaeectomy is attempted on a timely manner that prevents formation of anti-testis antibodies. Please really remember these decision point questions of high probability with 4 cardinal symptoms means immediate intervention, when the manual detorsion is attempted, when archaeopexy should be attempted versus archaeectomy, and when Doppler and other investigations are indicated. Each one of these could be a case either in standardized tests or in real life scenarios. Okay, returning back to the initial point, we mentioned that if the cardinal symptoms are not present, we perform Doppler studies. If there is no blood flow, we are dealing with torsion and we manage it as we mentioned. But if the patient has blood flow in the rule out category, we are dealing with testicular injury, the second most important rule out category when we deal with acute testicular symptoms. This is pretty much straightforward. What is the subjective and objective assessment? Well, the most important point is the patient mentions a history of trauma. So, very important question, true or false, a 15-year-old adolescent boy with history of trauma yesterday in soccer game now has come with unilateral testicular and scrotal pain. What is the next step in the workup? Still, we need to rule out torsion. Remember, trauma is itself a risk factor of torsion. Again, we need to perform the workup of torsion. regarding the timing and presence of cardinal symptoms and need for Doppler ultrasound. Another overlap is, remember that even though we say impaired blood flow is the hallmark of torsion, remember in severe trauma it's possible to also have impaired blood flow to the testis. Now, what would you see in the ultrasound Doppler studies of testicular trauma without impairment of blood flow? If we are dealing with an acute hemorrhage, we will see hyperechoic texture, echogenicities. But if we are dealing with an old hematoma, it will manifest hypoechoic. Old for hypo. That's how you can remember it. And what's the management for testicular trauma? Surgical repair. I have to finish this episode with this very important kind of warning case. I have heard from many physicians working in emergency room that knowledge of this could save a missed case or even the risk of lawsuit. You have an adolescent with abdominal pain, nausea, vomiting, and fever. What is one condition you need to make sure you don't miss and you need to rule out in this patient? Even though everything in the symptoms shouts that it is most likely gastroenteritis, abdominal pain, nausea, vomiting, fever, you need to rule out torsion. Pay attention to the fact that abdominal pain could be that radiated pain of scrotal swelling. Remember that patients with torsion and any type of acute process could have mild fever. Remember, nausea and vomiting is a possible finding in torsion. This patient has two of the cardinal symptoms of torsion. You need to at least examine the scrotum, at least investigate, and if you find anything more suspicious, you need to perform Doppler studies. So if you are asked what is the next step in the workup, remember many adolescents may not be able to openly discuss the scrotal symptom, or it may just be a true radiating pain to the abdominal region. So the very first step is scrotal exam for assessment of the pain, swelling, or high riding testis and bell clapper deformity. And this is our approach to the testicular emergencies, including torsion and testicular trauma. These are both part of differentials of acute testicular symptoms, including epididymitis, orchitis, and we will discuss them together with a couple other rule outs, including inguinal hernia, in a next episode on approaching testicular symptoms. Thank you.